Hello and welcome to another episode of the TheSynapse e-learning series. Today we'll be speaking about controversies in the use of bisphosphonates as a means for fracture prevention. And with us today we have Profs and Borg. Profs Borg, thank you
for accepting
Thank
you for the invite. Happy to be of help and participate in this debate.
Thank you. As the population ages, the prevalence of osteoporosis is obviously increasing, and with that comes the increased risk of fractures. And as we well know, there's also the service of bone mineral density testing, which is also able to detect asymptomatic patients with low bone mineral density and possibly choose them as a candidate for bisphosphonates therapy. So my first question to you, Profs, when should we consider starting active bisphosphonates therapy in these persons?
Okay, let us rephrase that. When should we consider starting treatment for osteoporosis? Because although bisphosphonates make up the major class of drugs that we use for osteoporosis treatment, they are not the only treatment. So let's look at when should we consider starting osteoporosis treatment. Basically, in anyone who is at risk of a fracture. Now, whether that is found incidentally on a bone density scan or because you suspect it from additional risk factors, for example, patients who are on steroids, patients who have active arthritis, patients with a very strong family history of fracture, patients with a very early menopause, then those would be clear criteria for considering starting treatment. What treatment you would start really depends on the age, on the fracture risk, whether the fracture risk is limited to cortical bone or to trabecular bone only, or to both sites. Men and women, you would use different medication. Well, it gives you additional options depending on the sex as well, because you might want to use testosterone replacement therapy in hypogonad men, and then clearly you would struggle to use specific estrogen receptor modulators in men.
Exactly. But speaking now about bisphosphonates, which is the topic of our interview, from your own point of experience, how well do bisphosphonates work?
Well, the fracture risk reduction is of the order of 50 to 70% from baseline risk. So, if your fracture risk is, let's say, 24% of a low trauma fracture, giving bisphosphonates will actually reduce that risk by 50 up to 70%, depending on your adherence. So it depends whether you are compliant with your medication, that you take it properly. That is, in the case of oral medications, that you take them on an empty stomach with a glass of water, preferably a low calcium water, and that you are persistent in your treatment, i.e. that you take it long enough that it keeps working, because the treatments are very much dependent on you taking them regularly. Now, because all the data shows that less than 50% of people will actually persist with oral medication, this has fueled the major interest in the injectable treatments, either the once yearly zoledronic acid or the 6-monthly rank ligand inhibitor denosumab. So because that way you can guarantee that the patient's taking your medication, while with oral medications you're always a bit vulnerable, because when the patients fail to see a direct immediate benefit from taking the tablet, i.e. doesn't relieve pain, doesn't make me feel better, they are likely to say, well, do I really need to take it every week? Can I skip it and I forget it and I feel no worse for missing it out?
Unfortunately, you don't see the benefit immediately.
No, it's a long-term benefit.
Exactly.
It's a long-term.
The use of bisphosphonates has also been mired with controversy, particularly after an article published in the British Medical Journal last year, which stated, and I quote, that in women without prior fracture there are no proven clinically meaningful benefits from bisphosphonate use in terms of total serious morbidity. or hip or wrist fractures, the two most frequent types of fractures associated with diagnosis of osteoporosis. And this article continues to say that basically in those who have had a prior fracture or a small magnitude of benefit was observed in meta-analysis of randomized controlled trials, an absolute risk reduction of only 1% was seen over 3 years in hip fracture and an absolute risk reduction of 1.3% in wrist fractures over 2.9 years. And this also continued in a Spanish independent organization which said that basically given that bisphosphonates can cause severe adverse effects including fractures, which they are actually meant to prevent, it is urgent that the overall benefits and harms of long-term benefit can be clarified. What are your comments about all this?
Interesting. And it's nice to quote from one individual study and not the overall body of research, because what is the ultimate bottom line? 1 in 5 men and 1 in 3 women over the age of 50 will sustain an osteoporotic related fracture throughout their lifetime. 50% of those who sustain a fracture remain disabled throughout life. 25% die as a direct result of their fracture. So I think when all is said and done, when you look at a population study as against individual patients, where you have clear identification of risk factors and fracture risk, I think that the data is stronger. When you do a meta-analysis and you pull up studies where there are patients who have low fracture risk, patients who are not fully adherent to medication, patients who are started in treatment for possibly very low fracture risk, you then really muddy the waters completely. But if you select your target population appropriately, i.e. patients who are at high risk of fracture, then I think that in itself warrants medication.
So undoubtedly right now the scales obviously push towards the use of bisphosphonates. They are positive in the...
I think so.
And there's also a lot of anxiety, especially by our dental colleagues, regarding osteonecrosis of the jaw and other side effects of bisphosphonates. So how common is this actually in clinical practice?
I really love this. I love this because I think there really is a misplaced concern among my dental colleagues on this issue. I have spoken to them about it at length, but it's really something where a little knowledge is a dangerous thing, with all respect to them. So, what is it all about? Well, osteonecrosis of the jaw can actually occur in patients taking strong anti-resorptive medication, whether these are the bisphosphonates or the rank-ligand inhibitors. They've not been reported with all osteoporotic drugs, but certainly with the more potent ones they have been. Right? The risk is actually greater if you are taking medications to prevent malignancy, because the dose of bisphosphonates there is much greater than the dose that you use in osteoporosis. Just to give you an example, zoledronic acid, which is the intravenous bisphosphonate for osteoporosis, the dose is 5 milligrams annually. When it is used to prevent bone metastasis or bone secondary to prostate cancer, breast cancer, ovarian cancer, you would use a dose of zoledronic acid of 4 milligrams monthly. So the cumulative dose is much higher. So most of the data relating to ONMJ relates to use of bisphosphonates in the cancer population, not in the osteoporotic population. But if you look at the hard research, right, results show that the incidence of ONMJ varies from 1 in 100,000 bisphosphonate users to 1 in 250,000 bisphosphonate users. So that's really just put the risk in perspective. There's a lot of fear of a very unlikely event. So if you look at just Malta, we don't have 100,000 patients taking bisphosphonates. you would you would not have more than one patient on the sort of drug every year in the Maltese island. So I think that the fear is sort of misplaced. Plus, what is the biggest risk factor for actually getting ONJ? It is poor dental hygiene. So if my dental colleagues want to make serious inroads inroads into allaying their own fear, best thing they can do is to encourage good dental hygiene in their patients, right? So the prophylactic treatment of dental caries, doing their major extractions, root and canal treatments before we start treatment. But to withhold treatment because of the fear of ONMJ is for me the wrong approach. The risk of fracture is much greater than the risk of ONJ.
And undoubtedly, the advice to maintain good dental hygiene doesn't apply only to this group, but obviously to all the patients and all the individuals. But we've spoken at length about bisphosphonates today, and we also should, I think, give some time to explain about other means to try to reduce the negative effects of osteoporosis. So apart from drug therapy, what can you advise?
Oh, this is if we really wanted to treat osteoporosis, we would do what is called primary prevention.
Exactly.
But this is a very hot potato. Why? Because it involves approaches from all sectors of life, including political life, governments also, to encourage healthy eating, to stop children eating lots of junk food, to reduce smoking, reduce alcohol, increase exercise and sports so that you can increase what is called peak bone mass. Peak bone mass is your bone bank of the future. You increase your bone strength exponentially until the age of about 30. Once you are 30 years old, you're at peak mass. You then maintain that mass until roughly the age of 45, 50. Following which there are a few years of rapid decline, followed by a gradual loss throughout life. And if we all lived long enough, we would all get osteoporosis. So what we are doing at this stage, we are treating the percentage of patients who develop osteoporosis. But if we really wanted to make serious inroads, primary prevention is the way forward. But it would take you 20-25 years to reap out the full results of your interventions. When you're doing lifestyle modifications, there are no quick research studies. So really, no one wants to do this type of work. No institutions, for lack of a better word, want to invest seriously for something that will be beneficial 25 years down the line, when someone else might gain the rewards of your intervention. So people go for a more quick intervention fix. But I think as doctors, we are obliged to keep on pushing the public health message for all our patients that really prevention is the way forward.
Exactly.
Is the way forward about that.
What is your take-home message about all this, Profs?
Okay, let's look at it. So, osteoporosis is a serious illness. Okay, there are more hospital beds in the over 50s which are lost due to osteoporosis than to cardiac failure or to chronic obstructive pulmonary disease, despite the latter two illnesses having a much higher profile. 2. Osteoporosis is both preventable and sort of treatable. And the last point, that the advantages of anti-resorptive therapies in reducing fracture risk outweigh the very small risk of osteonecrosis of the jaw and of atypical fractures. And finally, for my dental colleagues, the best way to prevent osteonecrosis of the jaw is to push for the highest standards of dental hygiene that we can in our population.
And with that, I thank you for accepting the invitation and being with
Very
us here
welcome.
today.
Hope it was useful.
And we hope that it has helped the audience to further their knowledge on the subject. We also invite you to like and share our Facebook page and keep yourself updated on the Synapse. Thank you.